It's finally here, the Q&A you have all been waiting for. Today, I speak with internationally recognized endometriosis expert and consultant gynecologist, Mr. Denis Tsepov. I first came across Mr. Tsepov when I decided to pursue private healthcare for my endometriosis. After my successful excision surgery with Denis and his MDT, I wanted to extend his expertise to women with endo who are desperately seeking answers, insights, and advice from a true endometriosis expert. So thank you to the hundreds of women who took the time to submit questions for this Q&A. You guys more or less covered every single key topic area, which has meant that we've had to split this Q&A into two parts. Denis's responses are so informative, so considerate, and I just know that many of you will find his words not just helpful, but validating. Sorry in advance for the abrupt ending. We kind of ran out of time, but rest assured there will be a part 2 that's coming soon. So without further ado, let's get into it. Welcome, Mr. Denis Tsepov, and thank you for joining me for this Q&A. I'm beyond excited to be discussing endometriosis with an endometriosis expert and to share your knowledge with my online community. I've personally been under your care and I feel privileged to have been able to do so. And I want to extend your expertise to the many women who are lost and confused with this disease. There's a lot of gaslighting and dismissal, and women need clarity, they need answers. You're a very informed and knowledgeable and compassionate and passionate endometriosis specialist. That's been my first-hand experience. You perform approximately 145 surgeries a year, and you're a teacher. You also train other gynecologists in robotic-assisted laparoscopy surgery. Your patient reviews, including mine, speak for themselves, and you work with an incredible multidisciplinary team. I must highlight your specialist endo nurse, Vicky, for her incredible care. Now, as you're aware, I asked women to submit their questions for this Q&A. I've filed every single question, and I've highlighted key topic areas, and we're going to dive into those today. But before we get started, is there anything you'd like to add, or do you want to just dive right in?
Thanks, Lina, for inviting me in. It's my pleasure to speak about endometriosis. Very limited knowledge, actually, of the disease will help us, the community, to understand a little bit more about what's happening, because it's the disease is very complex, it's very confusing, and it's very hard to treat. But we can talk about it, and maybe we can make it a little bit better.
Yes, I hope so. Okay, so to kick things off, the first subject area is the endometriosis stages, progression, and symptoms. So there's a lot of dismissal and gaslighting within the healthcare system. Women are often told these three things. You have painful periods, and that's normal. Endometriosis doesn't exist outside of the pelvis. We only detected minimal endo on your scans. So there's no need for surgery. So firstly, from your point of view, could you clear up any miscommunications around those statements and maybe just give a general basic description of what endometriosis is, where it can be found in the body, and modes of treatment?
So endometriosis is not just the painful periods, and you can have painful periods without endometriosis, but most of the time, painful periods, like extremely painful periods, is associated with either endometriosis or adenomyosis. And unfortunately, that's something we don't know really an answer to. You can have quite advanced stage endometriosis with very little pain, and you can have a very minor stage endometriosis with a lot of pain. So I guess in individual patients, the endometriosis behaves in an individual way. And that's factors like linked to genetics, immune dysfunction, inflammation types, hormonal signaling, and there is a difference between individuals. But what is important is when a patient presents to a health professional with a complaint of extremely painful periods, that never should be ignored, and it should be investigated. Investigation means you can have a very basic investigations, which most of the time would not actually reveal the disease, but you need to see a specialist, especially when the initial basic investigations at the primary care level came all back negative and the patient is still very symptomatic. Then it's not the point where you dismiss the patient, it's the point where you refer the patient further to see endometriosis specialist. So that's how endometriosis is diagnosed. We need a very detailed history. We need a very meticulous gynecological examination. We need advanced imaging, endometriosis grade MRI scan, endometriosis protocol MRI scan. And depending on the MRI, we either progress to look and see laparoscopy, plus minus excision of endometriosis if it's found, or if MRI is positive, we do it for the mapping of the disease, so we know exactly where endometriosis is, and then we can make a plan of treatment, either with gynecology endometriosis specialist alone, or as a multidisciplinary operation, and that's something endometriosis centers do.
Yeah, wow. That's a lot. That doesn't happen a lot of the time. It's that thorough investigation and the involvement of multidisciplinary team.
Well, unfortunately, yeah, I'm not saying it's a very simple disease. I'm saying it's super complex, and even within best endometriosis centers, best endometriosis minds in the world, we still have a lot of gaps in the knowledge, both on academic level and scientific level and on surgical level. So we're sort of approaching and advancing, but we're not by far reaching the final stop in this, because still a lot of patients suffer, even if we have the most successful surgery, and that's, we don't have an explanation to. It's a very complex and very, very tricky disease to treat.
Do we know how endometriosis progresses, or why it's deep infiltrating in some women and in other women it can stay at stage 1 or stage 2?
Well, that's very interesting questions, and we were asking that question ourselves. And we don't have a single proven progression pathway. It's more predictable in cancer, right? And thank God endometriosis isn't cancer. But in endometriosis, we can have progression very quickly. Within a year or two, it can go from beginning stage to end stage. And we can have, for example, patient with diagnosed, let's say, stage 3 or 4 endometriosis, and I'm using American fertility classification, stage 1 to 4. Then patient can reach stage 3 and stay stage 3 or stage 4 without further progression. Why does it happen, or why it progresses so quickly, or why it does not progress at all over the years? We really don't know. There is no single blood test or any sort of test when we're trying to predict how quickly endometriosis is going to progress. There is no test to understand what's happened to this endometriosis after excision. Is it going to recur? In this patient more likely, in this patient less likely, in this patient quicker recurrence and progression, in that patient no recurrence whatsoever. There is no knowledge about this, and the only estimation of progression is actually doing the MRI scans, seeing endometriosis and comparing to MRI scans 6 monthly or 12 monthly. So it's a lot of question marks rather than answers.
So it's very individual.
Yeah.
Yeah, unpredictable. What has been your experience of treating symptomatic endo patients in terms of staging? So, do you commonly find that if they're very symptomatic, they actually do have stage 3, stage 4 endo, or has it really varied?
Well, first of all, we're trying to move away from stage 1, stage 4 kind of staging. And now we are using the more advanced classification called NZN. And it's much more detailed, and it's much more accurate in terms of if two health professionals talking about staging of endometriosis, NZN classification is actually much more informative. But yes, there is also a discrepancy, and if the patient is very, very symptomatic, again, most of the times we have more advanced stage. Sometimes we have either like a few spots of endometriosis or no endometriosis whatsoever visible to us, right? This is more rare, but the general rule, if the patient is very symptomatic, especially if it's not just menstrual pain, also it's menstrual bowel symptoms, menstrual bladder symptoms, menstrual sort of sciatica, menstrual chest pain, that is very suspicious of advanced stage of endometriosis. But there is not always 100% sort of rule where the big symptoms means big stage, if that's what you're asking. I think the severity of endometriosis should be ruled out by investigations. You cannot just say, because your very basic ultrasound scan was normal, that means you're not having endometriosis. Because again, and the diagnosis is very tricky, and it's very dependent on the scale, on the level of the service that is making the diagnosis. And where we fail as health professionals at this point is a very symptomatic patient coming to primary care, let's say, or a general gynecologist with symptoms of endometriosis, textbook symptoms, right? Severe menstrual pain, severe pain during intercourse, severe bowel symptoms during periods, that's textbook. Normal scan by a very general sonographer who is not trained to do advanced endometriosis scanning, and the patient is dismissed based on that very basic, very superficial assessment. So that shouldn't be happening. We should, if we say, no, you don't have endometriosis, if the patient is symptomatic, that should be really, really proven by the advanced methods.
Okay, so a healthcare practitioner should be led by symptoms, and if they are classic endometriosis, especially severe, then they should be referred to see a specialist or to have scans done by sonographers, radiographers specializing in endometriosis.
Yeah, they shouldn't be dismissed in single word. They shouldn't be dismissed. And that's what's been happening quite a lot. Unfortunately, it's not just the problem in the UK, it's worldwide. And it's just the nature of the disease and complexity of it makes these patients dismissed and sort of normalized, if you like.
Yes, normalized, exactly. So I've also personally been told by a gynecologist in an BSGE accredited endo center. Many women have been told this line as well. Endometriosis only occurs in the pelvis. So if you have symptoms in your upper abdomen, in your chest, in your legs, it's not related. From your experience, have you found extrapelvic endometriosis?
Definitely. The most of the disease is confined to the pelvis, and that's reproductive organs, uterus, cervix, fallopian tubes, ovaries, and then the neighboring organs is bladder, bowel, ureters, also pelvic structures like pelvic nerves, superficial nerves, more deeper nerve structures like sciatic nerve, pudendal nerve, etc. We also
Yes.
saw it higher up in the abdomen, on the higher abdominal peritoneum. We saw it in the small bowel. We saw it in the appendix. We saw it in the cecum. We saw it in the diaphragm. We saw it in the umbilicus. We saw it in the surgical scars, and we saw it in the lungs. We saw it in the pericardium, which is the bag surrounding the heart. Yeah,
Yes.
and that's experience of a single surgeon, right? So it's much more. It's because we're focusing our care to endometriosis and complex endometriosis. We're perhaps seeing these unusual locations of endometriosis more often than a general gynecologist would do. But yes, we've seen it in strange places. Correct.
Wow. Right. Moving on to the next topic area, which is endometriosis and healthcare. So the gynecology classification, the link with autoimmune conditions, and the general healthcare system's attitude towards endo care. So endo currently sits under gynecology. It's been called a period disease. We know endometriosis can affect any part of the body, as you've just shared. Research has linked it to autoimmune disease, and it's more severe than your general menstrual health conditions. And it's even been likened to cancer. Yet women, as we've been talking about, are not taken seriously, and the wait times for care are increasing. So on that point, why is endometriosis currently still only recognized predominantly within gynecology, and why aren't other disciplines also specializing in endometriosis? So colorectal, urology, hepatology, cardiothoracic.
Okay, well, it's not only recognized in gynecology, but I mean, I see what you mean by us asking this question. The dominant symptoms of endometriosis are still pelvic pain, painful periods, painful sex, and infertility. So that makes it more belonging to gynecology than to urology, let's say, right? And
Yes.
traditional, diagnostic pathway is traditional first referral to a specialist would be to a gynecologist. Although sometimes we have referrals from colorectal and urology a patient who's gone full circle and went to in the end, got to the endometriosis specialist. But the modern endometriosis care is actually multidisciplinary. So I have 4 fantastic surgeons within my team, which are colorectal surgeons. And colorectal surgeons are mostly cancer surgeons, right? So the cancer surgeons, or they treat the inflammatory bowel disease. And these
Yeah.
surgeons also specialize in endometriosis because over the years, I have attracted them, first of all, as fantastic surgeons, fantastic clinicians. And then we learned together, and we learned that the evidence, we learned from other people, we learned how is best to operate on colorectal endometriosis, because the surgery, even if we talk about bowel resection, the bowel resection for endometriosis is different from bowel resection which you have for colorectal cancer, because it's not cancerous. Endometriosis, we do a very economical, very nerve-preserving bowel resection. And that's what makes a colorectal surgeon a colorectal endometriosis specialist, But you cannot have a colorectal surgeon doing only endometriosis, because that would be limiting his practice, because they're doing a much broader surgical spectrum. But it's important to have an understanding colorectal surgeon, understanding urologists, and urologists are mostly reconstructive urologists, the guys who can really remove endometriosis together with gynecologists and colorectal and reconstruct and urinary tract, like reimplant the ureter or reconstruct the bladder, and not cause severe nerve damage. And also cardiothoracic surgeons, they would know that endometriosis is not a lung cancer, so you don't have to remove half of the lung to treat endometriosis. And that's what makes a specialist center, MDTs, a very different breed of surgeons, because they are specializing in endometriosis. And it's only MDT, we think it's the only way of treating a very complex, multi-organ, multi-systemic disease involving multiple parts of the body.
So typically in an MDT, it will be led by a gynecologist because, as you've addressed, endometriosis predominantly occurs in the pelvis, and it's links with the menstrual cycle. So within an MDT, it would always be led by a gynecologist who then works in collaboration with the other specialists, especially a colorectal specialist. And you learn together. It's a collaboration to treat endometriosis. And you say a lot of those specialists come from a cancer
Correct.
background. Okay. So do you think endometriosis should be reclassified in any way? There's a lot of talk about this, and the frustration mainly comes because patients who are sent to gynecologists are kind of held hostage there, especially when the gynecologist isn't referring them to a specialist, or when they are seeing a colorectal specialist, there isn't much collaboration, as you say, between the various disciplines. So do you think that it should be reclassified?
Reclassified in what way?
As in the way it's being termed. So it's not just gynecological. Is it immunological? Is it autoimmune?
Well, no, although there is evidence of the immune system is disturbed in endometriosis, we cannot call endometriosis autoimmune disease, right? It's because it's inflammatory immune influence systemic condition, right? But it's not an autoimmune disease because there is no autoantigen, okay? For example, it's different, like it's not like rheumatoid arthritis. It's doesn't fit in the strict criteria of autoimmune disease where the specific autoantigen triggers the immune attack, right? So it cannot
Right.
be. There is an element of immune disturbance with this all because of inflammation and persistence of endometriosis tissue within the tissues. But endometriosis does not get better if you put a patient on immunosuppressant, right? So, strictly speaking, it's not an autoimmune disease. Yeah, I think we can change the terminology and we change classification, but it's not the main point. The main point is if we have a suffering patient, we should not ignore him.
Yeah. Yes, that's what it comes down to. On that point, the next topic area is getting an endometriosis diagnosis and the obstacle of medical gaslighting. So, endo is often not picked up on ultrasound or MRI. Then you've got these other forms of testing that exist, like the stool tests, calprotectin and the FIT, which detect inflammation in the bowel and blood in the stools. You've got the CA125 and the CRP for systemic inflammation. So, typically speaking, if endometriosis isn't detected, I rarely hear from women showing that there was further investigation. It's sort of like we didn't see it on imaging, and there's no additional sort of testing like the CA125 to see if maybe there are growths in the pelvis that could indicate endometriosis. I'm aware it's not a definitive diagnostic tool. And then women are typically refused surgery because they're scared off with post-operative scar tissue and with possible risks to their fertility. So MRI seems to be the best non-invasive diagnostic tool for endo. I know that you used it with me as your patient. What are its capabilities and what are the limitations?
Okay, that's a very good set of questions. So I'll start from the beginning. So the symptoms assessment is a critical starting point, right? So if the symptoms are there, then even if ultrasound scan is negative, if the MRI is negative, you still don't ignore the symptoms, because we know that superficial endometriosis can cause a lot of pain and it's not seen on the MRI. So that a negative MRI does not rule out endometriosis. So you need to do a laparoscopy. In the symptomatic patients with negative imaging, laparoscopy most of the time will reveal endometriosis. So, second point is there is a very big difference and variations on the quality of MRI scans and ultrasound scans, because some of the ultrasound scans can totally be spot on and as good as MRI. It's all operator dependent. It's all depending on skills of the operator. And some MRI scans can be very basic. As soon as the radiologist sees no cancer, they sort of lose interest. We've seen that as well. So it's all about who is doing what and which center of expertise is dealing with it. And false positive imaging does not rule out endometriosis, does not rule out severe scarring, and symptoms is the key. Symptoms is a very good starting point where the full investigation should be carried out. Okay, so other tests, CA125, we don't think this is very informative. We've seen there is some association with CA125 going up and down with endometriosis, but the value of CA125 is monitoring patients with ovarian cancer, a particular type of ovarian cancer, after treatment, right? So that's the only proven value of CA125. We do use CA125 sometimes, but it's not what makes a diagnosis. CRP is not a diagnostic tool. Calprotectin, FIT test, not a diagnosis. There is no blood or stool endo test or anything like this. So that makes it a bit tricky.
Yes.
But these patients should not be dismissed because there is a clear pathway how you tell the patient, yes, you do have endometriosis. No, you don't have endometriosis. And that's history taking, examination, imaging, and I put MRI and ultrasound, specialist ultrasound, more or less in the same category, and then inspection of the abdomen in a very particular way, which endometriosis center recommend.
Okay, so all of those other tests are non-specific. The strongest is the MRI. It's dependent on the operator, so radiologist, and laparoscopy surgery is the most definitive diagnostic tool. And these things should be afforded to people who have, as you're saying, those generic endo symptoms. Okay. There's been quite a few comments that women have shared of their experience in terms of trying to get an endometriosis diagnosis where they've had an MRI and MRI has detected suspected endometriosis. They're then put forward for laparoscopy surgery. They come out of surgery and they're told no endometriosis was found. I ask them if biopsies were taken, and half the cases they say yes, half the cases they say no. So what do you think happened? Has that ever happened to you where you've actually gone into surgery and you've seen no endometriosis despite MRI indicating there is?
That's extremely rare. That's extremely rare, and that happened to me, but that mostly happened to me when we used a general MRI, which was done outside the specialist setting. For example, like overseas MRI scan shows there is endometriosis. The patient did not want to repeat the MRI because either for financial reasons or she didn't like the feeling when she did have an MRI scan and contrast and the medication to stop the bowel peristalsis. So rare cases where we have, okay, we'll accept your MRI from, let's say, other country. And then when we went in, we didn't see any endometriosis at all. That's very rare. That's happened, but it's very rare. So also, it's important point to make is that when patients have laparoscopy, it's not just a little, let's have a look. It's a systematic, methodical inspection of the abdomen. So we don't have a look. We are searching for endometriosis in the symptomatic patient. And that's what makes a difference, because once you start searching, then in a symptomatic patient, almost certainly, almost in every case, you will find something which looks like endometriosis. In rare cases, it's totally pristine negative findings, negative for endometriosis. And you then start to investigate other causes of pain, ruling out endometriosis diagnosis. But you have to really search for it. And if you haven't found it, then it's not endometriosis.
Okay, so do you think one of the issues here with endometriosis not being picked up on in surgery is that a lot of the diagnostic laparoscopies that go on are performed by general gynecologists? Mine was, but he had an interest in endometriosis and I was diagnosed with an endometrioma. But a lot of surgeons who perform these diagnostic surgeries are general gynecologists as opposed to
I think
specialists.
there's an element of this, yes.
And what are your views on surgery being refused because a patient is quote unquote too young? You're too young to have endometriosis, or you're too young to have surgery, or because it will be detrimental to fertility, or because it'll most likely result in a stoma because of bowel endometriosis. What are your thoughts
Okay,
on
right.
that?
I mean, endometriosis is a disease predominantly affecting women in reproductive years. What's too young? It's really hard to say. We had the 16, 18-year-olds with severe bowel infiltrating endometriosis. Is that too young? And you know, overestimating surgical harm versus harm of the ongoing disease is overall, I think it's a bad thing because it delays diagnosis and people live many years with excruciating chronic pain, become sensitized and refused by the healthcare system because they've been refused, not just refused surgery, they refused a proper diagnostic pathway. I'm not talking about UK because this is a global problem. Lack of access to the experienced MDT dealing with endometriosis for either general gynecologists or general practitioners leads to avoidance or abandoning these patients, which is again the wrong thing to do. Okay, and the bowel and the surgery automatically mean a permanent stoma is a lot of nonsense because the risk of stoma, even if you have to have a bowel resection, is still very low. The new approaches, the modern surgery, especially robotic surgery, makes a permanent stoma extremely, extremely rare thing to happen. Temporary stoma, very rare. And it's just a lot of outdated knowledge out there, which unfortunately is pushed into the patients.
Yeah, thank you for that. Next area, endometriosis, leg pain, and nerve involvement. This is a big, I see it always on social media. Leg pain, it seems to be within 50% of the women I've come into contact with. Sciatica, pain shooting down from the hips into the thighs and the legs, numbness and tingling, even mobility issues. And also, this pain can either be new or worsened after surgery. I've come across quite a few women who've shared new leg pain after hysterectomy surgery. There's the coccyx pain, which is very common. I used to experience it. So, in your experience, I know you're not a leg specialist, but what are the possible causes foreleg pain with endometriosis?
Okay, it's a very good question, very good debate on this as well. So we know that leg pain is very common association with period pain, and it does not mean there is a nerve or sciatic nerve endometriosis. Okay, so if you imagine the pelvis is a structure which is supplied by multiple nerves, we have few main sort of main nerves, and they're branching into a network which is called inferior hypogastric plexus, for example, for the pelvis. And this network of nerves supplies everything from viscera like bowel and bladder and everything which goes there. If the tissues around the big nerves, for example, supplying the legs or the pelvic muscles or the lower pelvic structures are involved with peritoneal inflammation, that pain can be referred from pelvis to the legs. It doesn't mean there is a huge endometriosis on sciatic nerve. Sometimes it is. In this case, MRI will certainly see that. But most of the time, the leg pain and suspected nerve involvement comes with a negative MRI. And for these cases, we assume that this pain is to do with inflammation, and this pain is referred to the nerve rather than caused directly by compression of the nerve or sort of endometriosis growing into the nerve or something like this. Also important part of this, pelvic pain is dysfunction of pelvic floor muscles and other pelvic muscles as well. Because when you in pain, you instinctively start to position your posture and preserve some of the movements. You sort of change how your pelvic muscles work as well, and that can result in muscle spasms, which is independent source of pain, and it becomes very complicated. So the bottom line is leg pain during periods may not be at all associated with sciatic nerve involvement. Hypogastric nerve involvement, which is much more superficial than sciatic nerve, and that can happen with nodules on the pelvic peritoneum, pelvic lining, pressing on the nerve or creating inflammation around the nerve, and that can get you into dysfunction of the bowel, the bladder, sexual dysfunction, and smaller nerves can trigger the coccyx sort of tingling or pain and some other stuff, which you have to have a full sort of neurology assessment sometimes to understand what's going on and which nerve is involved.
Wow. So there's a lot more to it than simply you have endometriosis on your
Direct
nerves.
nerve involved with endometriosis is extremely rare.
That should bring a relief to many women because, as you're aware, the pain perception is heightened in many women with endometriosis, and they're almost convinced that it's hitting a nerve. That's how sharp it is. But you're saying it could be associated with nodules on the pelvic wall or inflammation created by lesions that's irritating the
That's right.
nerves. Good.
And if you have a negative MRI scan, and we can do like MRI scan specifically targeting, deep pelvic structures like sciatic nerve, etc. If it's negative, if there's no lump of endometriosis sitting there, then it becomes really tricky. Do you need to go and explore with surgery and see if you can find something? Or that would be my first choice. My first choice will be to get them to see a chronic pain specialist, do the pelvic physio, as sometimes they will need to use like neuropathic pain medications like gabapentins or the medications which modify nerve response to the pain, or targeted injections, nerve blocks, and it's all part of multidisciplinary team again. So we can involve the chronic pain specialist, who is a works with musculoskeletal specialists with pelvic physio, and the going and exploring what the sciatic nerve is doing surgically is a very high risk strategy, and it's only maybe one or two specialists in the country who have skills to actually do the neuro endometriosis. And most of the time, they use confirmed imaging findings to be able to identify the, for example, sciatic nerve endometriosis and go and treat it. So it's more tricky than you think.
Wow. Yes, got only one or two specialists. Gosh. So just to clarify, when it comes to imaging and nerves with regard to endometriosis, did you say that a negative MRI means gives cause for surgical investigation, or it needs to be picked up on MRI for you to identify that there actually is endometriosis on nerves? Like it is detectable on MRI. Is there a special neuro
No,
MRI?
MRI will detect something with the volume, right? If it's a lump, okay, pressing on sciatic nerve, MRI will see that. Yeah, if it's peritoneal endometriosis creating inflammation and deferred pain, then MRI is not going to detect that, but laparoscopy will.
Right, right. Okay. Got yeah. That really helps clear up the investigation to diagnosis process. That most women are just told it's not your nerves, it's which as we've established, it most likely isn't directly on the nerves.
That's right.
Okay. So moving on to diaphragmatic and thoracic endometriosis. Now, when I heard about it, it was years ago, but there was one case that I knew about. And then, of course, I, with you, was diagnosed with diaphragmatic endo via MRI and then treated during laparoscopy. And since engaging with the online community, it seems to be a lot more common than it's actually being made out to be. So things like cyclical symptoms of chest pain, breathlessness, pneumothorax, rib pain, shoulder tip pain, blood and sputum, chest infections, and even the upper abdominal digestive symptoms, which is what I had. Diaphragmatic and thoracic endometriosis seems to be notoriously difficult to detect, and so many women end up in A&E when they bleed, and they're typically sent for an X-ray. They say it comes back negative and they're just sent home, and this just repeats. And it's even more difficult than with pelvic endo because we're lacking, it seems, the thoracic specialists. And then there's the surgery risk. So I understand that not all women are going to be thrust into surgery because it's more complicated than a pelvic laparoscopy. So questions to you on that front are, what are the best ways to diagnose it, to diagnose diaphragmatic and thoracic endo? And what are a patient's treatment
Okay,
options?
good question. Yeah, so we do see a lot of patients with confirmed diaphragmatic endometriosis. They normally present with a pile of normal ECGs, electrocardiograms, because they have periods, they have chest pain, they go to A&E with chest pain by ambulance, thinking they have a heart attack. They do ECG and send them home with a negative normal report. So these kind of patients, and the patient with catamenial pneumothorax also we see. And the tricky part with thoracic endometriosis, it's not very often seen on the MRI scan. So maybe less than 20-25% of the cases confirmed diaphragmatic endo we see on the MRI scan.
Wow.
Typically, these patients will have pelvic disease. And if they're symptomatic for the chest or diaphragmatic endometriosis, what we'll do, it depends what type of job we need to do in the pelvis. For example, if we just do excision, then we definitely look at the diaphragm as part of a routine sort of pelvic survey, okay, pelvic abdominal survey. If we see the infiltrating diaphragmatic endo with negative MRI scan, then we try and not to treat it if, for example, we have to treat bowel endometriosis at the same time. So a lot of our patients will have severe pelvic disease, which is treated as a stage 1, and then we move for thoracic endometriosis, for diaphragmatic endometriosis as stage 2. And we use both abdominal approach and we use thoracic approach with thoracoscopy to treat thoracic and diaphragmatic endometriosis. And again, this is totally MDT based service, right? So we have hepatobiliary service in our center, we have thoracic service, and we like to involve them. They're mostly cancer specialists, right? But they have special knowledge of endometriosis and they know how to do a very economical but yet radical excision of diaphragmatic endo and the endo in the lungs.
So I've heard from women who have suspected diaphragmatic endo from symptoms alone. rarely the gynecologist will say, we're doing a laparoscopy, take a quick look. And they're just told we didn't see anything. And from when I watch back my surgery video and I see just how meticulously you had to navigate my upper abdomen to get a good look at my diaphragm, and you had involved a hepatobiliary specialist, would you say that in those cases where a gynecologist is just taking a quick look, it can be
Well,
missed?
quick look normally is not a good strategy. You have to either search for it or not bother, right? So, yeah,
Yes.
and quick look often looks at the anterior or the front part of the diaphragm. Most severe endometriosis on the diaphragm that we saw is actually at the back of the diaphragm, which is obstructed by the liver. So you will need to have access to that part to be
Mm,
able to tell. And that's searching for it, not just having a quick look. Quick look is not good.
no. Thank you for clarifying. So the next area is medication. You know how I feel about that, but that's based on what a lot of women have experienced with medication, where diagnosis or no diagnosis, just try this, it didn't work, try this pill, try chemical menopause. So the main medications that we've come across as patients for endometriosis is the combined contraceptive pill, progesterone only, Myrinecoil, Rayco, Dianogest, chemical menopause like Zoladex, NSAIDs, and your top tier painkillers like opium grade or like codeine. So, what are your thoughts on medication and their general effectiveness for managing
Well,
endometriosis?
first of all, it's important to understand that there is no medication yet invented who would make endometriosis go away. Okay, any medication that we use, from a moderate suppressant grade like progesterone only pill or Myrinecoil, go into the stronger suppressants like Dianogest, which is also synthetic progesterone, and then Zoladex, Prostap, sort of Rayco. These medications will suppress uh, estrogen activity or suppress endometriotic glands, and they're not going to cure it. Okay, so with medication, we use medication instead of surgery only in specific circumstances. For example, patient doesn't want to have surgery or cannot have surgery for whatever reason, to minimize the impact on the symptom of the endometriosis for the patient's pain and quality of life. We can say, okay, why don't we start you on medication to try and ease off the symptoms while the idea of surgery becomes more feasible. We use these medications much more often for after the excisional surgery, and that is to stop the recurrence of the disease, because they're very good in stopping the recurrence, because endometriosis can be recurring, and even with the best, most radical excision, it still can come back. And the different organs have different risk of recurrence. For example, the ovaries, if you do the cystectomy, the risk of recurrence in the natural cycle is about 20-25%, which is quite high. On the bowel, if you do the shaving, the risk is maybe less than 10%. If you do bowel resection, the risk is about 1-2%. So the rate of recurrence is different. But if you put a patient on either on Dianogest or the Ryeco, and for example, they want to be on it for some time or until they're ready to become pregnant, for example, that really minimizes the risk of recurrence. That's the value of medication we use. You know, the non-steroidals, opioids, they just painkillers, they're anti-inflammatory opioid. You have to be careful with opioids because they have many unpleasant side effects as well.
So, in your experience, you've seen the strong synthetic progesterones like Dianogest more effective after surgery in terms of reoccurrence, as opposed to pre-surgery and slowing down or stopping
Well,
progression?
they can be used before the surgery or instead of surgery, but with in individual circumstances. But you don't cure endometriosis with Dianogest. It's just a suppressant therapy. It can be used before surgery in specific circumstances, but most effective they are after the surgery when endometriosis is eradicated and then we put hormonal suppression to minimize the risk of recurrence. For example, someone wants to get pregnant but has adenomyosis, which we cannot remove surgically without doing a hysterectomy, and she's not planning a pregnancy within the next year. This is a perfect candidate for a trial of hormonal therapy. And hormonal therapy also has its side effects. And what we do, we normally will try for 3 months first. Most of the time, side effects will settle down after 3 months. But it's all try and see approach. We can try one agent, we can try different agents and see what's best for the patient. So there is no test which will tell us this Dianogest is best for Mary and Rayeko is best for Clarissa. It's not such thing. So it's only try and see. They're all safe medications, but they can be tolerated in a different way.
And at the moment, it is just hormonal suppression, because there are many women that have asked, hormones don't sit right with me. Is there anything non-hormonal to help with endo, aside from pain management?
Not really. Not at the moment.
No. Okay, I thought that. So if we move on now to hysterectomy and is it oophorectomy?
You can call it oophorectomy, yeah.
Okay, oophorectomy. So I've come across one too many women who have been given hysterectomies or oophorectomies with and without any sort of diagnosis, like not even endometriosis, not adenomyosis. It's just they've got these pelvic symptoms and it's decided that the reproductive organs are to blame because they're cyclical, so let's take them out. And of course, in cases of endometriosis, there's disease progression, the symptoms persist. So what are your thoughts on hysterectomy as a treatment for endometriosis, and should it be secondary to excision surgery?
Well, a very good question. And as always, the devil is in details, right? So it's very difficult to exactly localize the main predominant source of pain in endometriosis patients. And we know that endometriosis and adenomyosis are seen together very, very often, like 80-90% of cases. So if we want, let's say have like hypothetical situation where we have a patient who is suffering a lot from endometriosis symptoms, and she's finished with her fertility. She had enough children and she's not interested in more pregnancies. And she has severe pelvic disease like bowel disease or bladder disease or both, peritoneal disease, and adenomyosis. So the best surgical treatment for this type of patient will be excision of endometriosis plus hysterectomy. And we know for sure that that will provide a more sustained and more long-lasting relief of pain. However, if you do only hysterectomy but leave the bowel and peritoneal disease behind, that's not going to do anything to her pain. It may stop her bleeding, but the pain will still be caused by residual endometriosis. Okay? The same as removing all endometriosis, but leaving a huge adenomyotic uterus behind, that may relieve some pain, but if the uterus is predominant cause of pain, then this pain is not going to change. And I know it's easy for me to say remove everything just because I'm a surgeon, but with endometriosis, we have individual approach to this because some people would still want to get pregnant. That's why you cannot remove the uterus. Some people would say, no, I definitely finished with pregnancies. I have enough children, or I stopped trying, but I want to get rid of the pain. In this case, hysterectomy as part of the endometriosis treatment, not instead of endometriosis treatment. And that's a viable solution. Make sense?
Yes. And in terms of oophorectomy, if a woman has her ovaries removed, can that put an end to endometriosis, given that the saying is that the ovaries are producing the hormones, estrogen, and that's what's fueling your endometriosis. So if we get rid of them, all endometriosis will die out eventually, including extrapelvic.
Yeah, again, there are nuances. So if you, for example, have a huge nodule on the bowel, which is symptomatic, and you remove the ovaries, yeah, the effect will be similar to effect of unopposed GnRH analog like Zoladex, right? And some people will have relief in symptoms, some people will not. Because if endometriosis is affecting the nerves and like deeper structures already by fibrosis and infiltration into the tissue, that pain still can persist, right? And the removal of the ovaries without clearing endometriosis will sometimes achieve some relief in pain, sometimes not. Okay, so it's basically removal, excision of the disease as much as you can. Again, in individual circumstances, then this excision can be more radical or less radical. But another nuance is when you remove ovaries in a young person, then the suffering
Yes.
from menopausal symptoms can be really unpleasant. And these people will eventually say, okay, I want some HRT. And when they start on HRT, then the whole thing can be activated again, minus the ovaries, so that you have to be really careful, because if the patient is still suffering with endometriosis at the age of 50, for example, she is not in menopause quite yet, but she doesn't want to leave the ovaries, and that's again individual decision. Some people will want to keep the ovaries, some people won't. And that's
Yeah.
debatable. That's individually approached, and there's no single answer who should have the ovaries out and who should keep the ovaries, because a lot of it is discussion with the patient. A lot of it is taking into consideration what patient wants to do versus the knowledge of consequences. What happens if we do this? What happens if we do that? And above this all, there is element of unpredictable.
Yes, exactly. That so you're saying it has to be a very thorough individual approach based on the context of the patient's age, where they stand on fertility, and the prospect of menopause, and the need for HRT, all being factors that simply removing the ovaries is not a fix.
Yes.
Generally speaking. Okay, thank you for clearing that up for us. So that concludes part 1. But as I said, fear not, because part 2 is coming soon, where we address all of the hot topics you wanted answers on, including excision surgery as a management tool and why aftercare is required, sick leave after surgery, silent kidney loss, how does it happen, how can it be caught early, fertility, pregnancy and IVF with endometriosis, menopause and endometriosis, and finally, endometriosis and cancer. I will see you there.